Thank you, Cynthia. And I wanted to thank the Planning Committee for having me here today to discuss this interesting topic with you all. So I have no relevant financial disclosures. I feel that the real key to succeeding with any advanced technology IOL is really, first of all, understanding your patient desires. It then comes down to setting the appropriate expectations with them. And then we have to understand the various technologies, because we're only as good as our technologies can afford us the opportunity to be so. We would love to have a 25-year-old crystalline lens that we can implant into the eye, and that just doesn't exist. And so the reality is that we have to remain flexible about working with the patients to try to figure out how we can achieve their goals. And so I'd like to start with some cases here. This is a 61-year-old orchestra conductor who presented to me for a cataract evaluation, and he wants glasses independence, and these are his best corrected visual acuities with about a -8. But when I looked at his cataract, I didn't really think that it was a 20/40 cataract in that left eye. And certainly on his macula OCT, he was noted to have a resolving PED, and therefore I referred him to my retina specialist, who felt like this was probably inactive CSR. He watched him for about 6 months, thought it was fully inactive, and sent him back to me for his cataract surgery. So now I need to talk to him about what his wants are. And I know that he wants to have excellent distance vision, and that in fact he told me he wants to be able to read his music stand music when he's conducting. So in my mind, that's a little bit of intermediate. However, he is aware of that dark spot in his left eye vision. And so I had to set the appropriate expectations. And I said to him, listen, I understand your need for broader range of vision, but I'm concerned about that advanced technology lens in your left eye. So he put his trust in me, he understood my concerns, and this is what we decided. So we were gonna proceed with the left eye first, which actually was his dominant eye, and aim for excellent distance vision with a monofocal lens. And in that right eye, we'd probably plan for either an active focus or a symphony, extended depth of focus, or one of the low-ad multifocal IOLs. And in his left eye, he ended up with plano, and he's really happy with his distance vision overall. However, he's struggling to read his music. And so we decided to proceed with an EDOF for the excellent distance and intermediate in that right eye. And the outcome is he was thrilled. So this was a wonderful outcome where we mixed the technologies. But my last prescription to him was the Ultimate Guide box set for meditation, so he doesn't get CSR again in that other eye. So now we're going to move on to case number 2.
There's a side note. Priyanka is a yoga teacher on the side.
Yes. So I know the importance of it. So the next one is a 42-year-old female who presented for laser vision correction. And her uncorrected visual acuity is here, and that's her manifest refraction. So she's a latent hyperope in that right eye, and she's a super hyperope in the other eye. And she's maybe a little bit amblyopic in that left eye, and she's been evaluated in the past for laser vision correction and told that there's really no great options for her. So I know what her wants are. She wants to have excellent vision at all distances, and she wore contact lenses for a really long time in that left eye, but she's become a little bit more contact lens intolerant, and she just can't tolerate her glasses with that +5 in one eye and the +150 in the other. She's a PhD student. She's already read up on all of the technologies. She's been evaluated for LVC before, so she knows she's not a slam dunk case. So I'm setting the appropriate expectations. Listen, hyperopic LASIK, not necessarily as predictable of outcomes, and certainly not a candidate for that left eye. I tell her this is going to be a journey and not a quick fix, and I'd like to go on the journey with you. And she understands my concerns, and she's interested in proceeding. So we decide we're going to proceed with that left eye first, and we plan for an active focus with femto LRIs. We're going to hold off on any intervention in the right eye. I say, listen, you're uncorrected 20/20. Let's give you the opportunity to just correct that other eye. If you need to wear one contact lens occasionally, or we figure something out with your right eye, let's just see where we go. But in the interim between her evaluation and her surgery, the PanOptix is approved. So I give her a phone call and I say, listen, this lens is approved. She's very well aware of the lens, but hadn't been aware that it had gotten approved. And she's interested in giving it a shot. So that's what we decide to proceed with. And at post-op week 1, she's 20/30 plus and J1. She's having a little bit of trouble adjusting, but when I show her monocular vision in that eye, she's really excited about it. She ended up a little bit myopic, although she was also very dry on exam. So I said, you know what, let's give you a little bit more time. We'll see where you end up. Maybe we need to tweak that left eye. Maybe we need to proceed with doing something in the right eye. And so the plan is still up in the air because she was supposed to show up for her month 1 last week and she had to cancel. But she is still excited to move forward. So going through my typical kind of surgical plan, on any patient who's interested in a premium technology lens, and for the most part on any cataract eval, I'm going to get a topography, I'll check their eye dominance, and I'll get a macula OCT. always considering patient needs. The reality is that every patient has different needs. I mean, I'm someone who's quite vertically challenged, and I know that I'm going to need more plus power if I decide to go with an advanced technology lens someday than maybe my 6'3" colleagues who don't need that much of a range of vision. And so considering those things is really important. My typical thought process before about 2 months ago when the PanOptics came out was I'd proceed with the dominant eye first, plan for the active focus or symphony depending on the patient needs. Now with the PanOptics, this might be changing a little bit, although we'll talk more in a moment. And then after the first eye, I ask if they're happy with their near vision. And if they aren't happy, then maybe I'll decide to do a multifocal with a higher add power. Or I ask if they notice significant glare or halo symptoms. And if they do, and they're very bothersome, well, then maybe we'll proceed with a monofocal lens in that eye. And so there are a lot of different options for mixing and matching. One of the things I wanted to highlight was this review article from 2016, that the 2 studies that I really wanted to pull from it was the first study that showed that there's really no difference in uncorrected visual acuity or stereopsis when you cross or use conventional monovision. So what this says to me is that we so feel like dominance is black and white, and it's not. It's very gray. You actually can make the dominant eye have the near vision and have the non-dominant eye have the distance vision, and generally speaking, patients will tolerate it. So the second study, it's not so much about how well they tolerated the monovision or not, but more so that the numbers aren't as different as you would think. So the crossed versus the conventional had pretty close, 55 versus 70% acceptance of the monovision. And I think that's something for all of us to keep in mind as we're moving through this process with the patient. So understanding the technologies is huge, and these are just a few of the studies that kind of highlight how the studies work, but for me, I break it down as simply as I can for my mind. And that means with the multifocal IOL, your light is going to be split for distance and near, and so we know that this has the potential for decreased contrast sensitivity, the risk of glare and halo. We know that with the higher power adds, we used to have that loss of the intermediate vision and the higher dysphotopsias. And so with the lower power adds, we got better distance and intermediate, but patients really relied on their reading glasses for the near vision. And you could do a little bit of the blending. So maybe aim for plano in the dominant eye and aiming for the -0.5 in the non-dominant. With the EDOFs, you can get less chromatic aberration. You can still get the spider web glare and halo, but you can also blend with these, as Mitch's talk just described, blending to get that better range of vision. And now with trifocal IOLs, we know that these give the best uncorrected near visual acuity of any of the technologies that we have out there. Now there is still risk of glare and halo and still some risk for decreased contrast sensitivity because you're splitting the light, but it's exciting new technology. The interesting thing, though, is while we think that maybe this is the turn of the next step towards correcting patients' vision, this study came out this summer that suggests that there is still photic phenomenon that is more significant in bilateral trifocal implantation compared to bilateral EDOF implantation. And with their monofocals, it was less. So it was 6% with the EDOFs, 10% with the trifocals, 0% with the monovision, and 2% with monofocals. So I think mixing and matching may still be on the horizon for us. And certainly there have been a few studies that have just come out, a couple of them within the last year. The top one just kind of highlights how bilateral trifocals certainly works better than the low add with the high add power. And so I think as our OUS partners have seen, maybe those bifocal technologies are going to be getting phased out. The next one, looking at trifocal with a low add in the dominant, actually gets wonderful results. And then the final one, looking at bilateral EDOF versus the EDOF in the dominant eye with the trifocal in the non-dominant eye, can give really great results. There was nothing with the bilateral trifocal versus a mix and match, so likely studies will be continuing to come. I think it always comes back down to these 3 things. If we understand our patient desires and we set the appropriate expectations, and we understand the technologies to the best of our abilities and try to remain flexible, we'll always continue to do the best we can for our patients. Thank you.